Good afternoon, everyone. See that people are still joining. They're jumping on in pretty high numbers here. But I think we are ready to get started so that we can make sure that you get to hear the entire story today. So my name is Tracy Pate, and I am a Public Health Emergency Preparedness Specialist with IPRO, and I work out of the Beechwood office in Ohio. And I'm the host that you're going to see on the camera today for our presentation, but I assure you there is a huge supporting cast behind the scenes, making sure that we get to share this information with all of you today. We hope that you all find true value in this presentation and that you have a little bit of fun, even though we are talking about disasters. It was a truly special experience for what I would consider one of the most dedicated teams I've worked with to put all of this together and really bring this all to life. So it was truly a collaborative effort. So those of you on the planning team who are working behind the scenes today, my heartfelt gratitude to all of you. It's really through the collaborative nature of programs like this that the true spirit of emergency preparedness actually gets to shine. And I can't thank you guys enough. And I can't thank all of you for joining us today. So next slide, please, Ryan. As with all meetings, virtual or in person, there are housekeeping items to go over before we get to go the good part. So you can go ahead to the next slide, please. We are taking questions and comments in the chat, and I do see that people have been introducing themselves and their facilities and their roles in the chat box. We do have someone monitoring that box for questions. Feel free to use it at any time during the presentation. And if our chat monitor sees that there's a lot of questions stacking up, she will stop us for a second so that we can maybe field some of the questions as they come in, just so that we don't get backed up towards the end of the presentation and we can address all the questions that we can. That being said, we'll go to the next slide. The session is being recorded. You may have noticed that little notice up at the top left corner of your screen. Although we do encourage you to participate and ask questions at any time, you are all on mute, and we're asking you to stay on mute unless you have a question. We certainly encourage participation. We just don't want to hear you crunching your potato chips at lunchtime, because I know that a lot of you are probably eating lunch as we present to you. And when you're asking a question in the chat, just like you guys have been introducing yourselves, you know, we can see your name in the chat. If you just want to share your facility or what type of facility you work at and your role within that organization, that'd be awesome. If you're feeling brave and you want to ask a question live, just share your name with us and the same information, the type of facility you work at and your role within that facility. Next slide, Ryan. This is a little information about IPRO QIN-QIO. For those of you who don't know, we are a federally funded Medicare Quality Innovation Network, quality improvement organization in contract with the Centers for Medicaid and Medicare Services. There's 12 regional CMS QIN-QIOs nationally. IPRO is one of them, and you can see the states represented there. HealthCentric is another partner that has worked very hard with us on this project, and then also Clarent. So again, thank you. I cannot say thank you enough to everyone that helped put all of this together. That being said, our speaker for today is Stacy Radcliffe, who comes to us from Maryland, although she travels everywhere lately. And Stacy has been a licensed nursing home administrator for about 35 years. She has held that license in 5 states throughout her career. Stacy lives in Maryland with her husband. She has 3 adult children. She calls herself an empty nester, and she said that proudly, as all 3 of the children are off on their own. She and her husband enjoy sailing, and she is a backyard beekeeper. My mistake, beekeeper. As a result of the event that happened at her facility, Stacy has become more involved in emergency preparedness efforts within her community. And I think that goes to show the true nature of emergency preparedness is that, until you go through something like this, you don't really know the impact that it will have on you. And I'm really glad that Stacy is now sharing her experience within her community. I asked Stacy when we were doing her bio who she would like to play her in the Hollywood version of the story you are about to hear. And she chose Sandra Bullock. And I think that that is very fitting as you meet Stacy and she tells her story. She has a tremendous sense of humor and frankness when she is getting into the nuts and bolts of her event. And I think that you're all really going to enjoy that. We encourage you to listen, take notes. We all read after action reports. We all, attend conferences where people put on presentations that are very polished and sanitized and diplomatic. We're really going to be frank. We're going to be very truthful with what happened here in this platform. And I really encourage you to take notes and ask questions either during the session or after the session. We will get you the answers you seek. And without further ado, we will go to the next slide. And Ryan is going to play a little video for us. And this is, this is where to get your notebooks ready. This is really going to set the stage for the story that Stacy is going to share with us. And you can consider the news clip of this event kind of like the movie trailer if you want. And go ahead and hit play, Ryan.
Back to breaking news in Bowie, Maryland. The sunlight is giving us a better look at an explosion at a senior living facility.
Yeah, it's on Health Center Drive, right next to the Bowie Town Center. And Megan McGrath is there live. She's been there for more than an hour now with the latest look at the damage. Megan, good morning.
Well, good morning. This was an explosion in the kitchen area of this facility. I'll step out of the way and you can see just how much damage was done here. Now, this is Larkin Chase. It's a senior living and rehabilitation center in Bowie. And what you're looking at here is the back of this brick and mortar structure. This is the kitchen area. And you can see how the bricks have just been blown away by this explosion that happened just a little bit before 4 o'clock this morning. There was a fire, we're told, and that created some smoky conditions inside the building. Now, obviously, because of the type of health facility this is, the residents here are elderly and in frail condition. There was real concern about their safety with the smoky conditions. Now, the good news here is that we're told that nobody was injured, but there is a situation now involving the electricity and the air conditioning. They had to cut the electricity to the building because of this extensive damage, and we've got some very humid conditions as well as some heat that's going to be coming this afternoon. So the decision is being discussed right now as to whether to evacuate all of the residents or not. We're told that people are sheltering in place at this point. But again, the good news here is that while a lot of damage was done to the back of the building, nobody was injured. Back to you.
Yeah, that's surprising and definitely good news considering all that destruction. Megan McGrath live for us in Bowie. Megan, thank you.
At this point, we are ready to hand the presentation over to Stacy, who's going to take it from here. Are you with us, Stacy?
I am. Thank you, everybody, for coming. The video sort of makes it still rather hard to believe that actually happened. This actually happened in June of 2022. So Larkin Chase is part of the Genesis Healthcare Center organization. It is a one-story building, which is obviously helped us a great deal. It's 120 bed capacity outside of Bowie, Maryland, which is outside Washington, D.C. We employ approximately 120 some staff members, but only 14 were working on the night shift. And what actually happened was, for some unknown reason, the alarm sounded at 3:35 a.m. And I'm going to just give you a statement of the event, and then we're going to talk a little bit more. At 3:55, our maintenance director responded to the building because it was an unknown reason, and the local fire department responded as well, only with their usual equipment. And then within a matter of minutes, the entire back half of the building exploded after the fire department had left. That back half of the building included the kitchen, the laundry, mechanical rooms, offices, dining rooms, and patient rooms. Next. So what happened inside the building? The generator was rendered inoperable. The blast actually sheared the main distribution panel and became fired and was unable to be used. The main sprinkler pipe sheared and sort of created a geyser on the top of the roof with several inches of water in the floor. The sprinklers didn't actually go off, which was a good thing, because the patients would have been more scared to have been laying in their beds wet. Thankfully, they were not. We had absolutely no lights. This was 4 o'clock in the morning, and the generator simply did not start. If any of you are nearby the Washington area, you know June is the beginning of crazy humid weather. So there was, at that point, 4 o'clock in the morning, no air conditioning, and temperatures were due to rise. The building inside, when I reported to Incident Command in the back, it was a very concerning situation. I was unsure what I was going to see. I was scared. It was completely dark outside. It was completely dark inside. People had a hard time seeing each other inside the building, and it smelled of the diesel fuel. And honestly, I didn't know that I would even find casualties when I walked in. And as you heard, we did not have any casualties or any injuries at all. And I think the looks on the staff's faces and the patients' faces was something that's been hard to manage. And even, I say, the Incident Command certainly looked extremely confident, but perhaps a little rattled. Next. So these are some pictures on the right-hand side of your screen. You can see the actual main distribution frame that was blown. Those silver pipes are the pipes to the generator. On the left-hand side is a different view from the back of the building. Next. You can see that along the other side, it just was a complete collapse across the back. And across that back is the kitchen, patient rooms, all the service area. Next. So we had a successful evacuation. Under the local fire department and the Larkin Chase staff, we did successfully evacuate 111 residents in under 4 hours. The initial evacuation site was the local senior center, but it was not the site designated in our plan. And we're going to talk about that in a little bit more information. Eventually, residents were located to 17 different facilities and in skilled nursing beds by 3 o'clock that afternoon. There were no injuries to patients and staff. And again, as Tracy said, a little brevity is important in my life anyway. But about a couple of days later, we realized that the fish were in the back in their tank with no electricity. So these were quite beloved animals in our building. So we had to go rushing in, and we were added to our feather and our cap that the fish even survived because the local fish company came and dug them out. So we are feeling pretty good about that. Next. So I want to talk a little bit about a reality here. And one of the things I wanted to talk about was what we're supposed to do and what we do. We are required under the Code of Federal Regulations 483.3 to maintain that emergency preparedness plan. We must develop and maintain it. And we did. We had one and we drilled as we were required. Our books are not perfect. We're no different than anybody else on this call. We try really hard, but nothing is perfect. And during this last several years with COVID, some things are not as good as they used to be. And I venture to say, because we've had waivers for emergency preparedness and drilling and so forth, that this might have been one area. incident command vest system. I had that kit. And I had trained all of the staff several years ago, a year and a half ago, on the hospital incident command chart, that somebody had to be incident command. I had a vest, the whole thing. So when I got there at, just around 4:45, I got my vest out and I headed down the hallway handing out the vests. I had the clipboards. I had the evacuation documents. And the incident command EMS in the building looked at me and he said, "We don't have time for your plan. This is what we're doing. Let's go." And I just sort of stood there, not sure what to do. And at that time, two burly, strong firemen whizzed behind me with a lady in an office chair. And I turned around and I said, "We don't evacuate our patients in an office chair." He said, "That's what we're doing right now." So one of the things we learned was that sometimes the best plans are not the plans that will work. This emergency was clearly outside the scope of our emergency preparedness plan. The EPP doesn't necessarily have a plan for when everything is gone, here's what you do. So our relationship that morning with incident command and EMS is part of the reason we had such a successful situation. Next, please. So every administrator's worst nightmare since 2019 has been their annual survey, because many of us on the East Coast anyway haven't had surveys since 2019 with COVID. So the week before the blast, which was June 14th, the annual survey team showed up to do our annual survey. So not only were we in this incredibly difficult, challenging, and emotional emergency, we did all of this under the watchful eye of our survey team. And the administrators on the call, you probably had seen this before. The surveyors show up around 8 in the morning, 7:30 sometimes. They have their rolling briefcases in their bags and they come up to the building and you say, "Oh, good morning." And they come in and you get started. Well, imagine their faces when they showed up on that morning. It was a little challenging for all of us, but we made it through. And I'm happy to say that we did not get any deficient practice. And again, that emergency preparedness plan was unavailable for us to use. I couldn't find it. We couldn't see it. We couldn't read it. And it didn't even apply. And I think that's the mission of my situation here today and others, is to try to look at what are we currently doing that we can maybe do a little better or work a little smarter, because nobody can work any harder than the way we've been working. The nursing centers across our country is extremely stressed. Resources and commitments are waning everywhere. So how do we do it? Next. So was it good luck? Was it good planning? Was it something else? I think it was probably all three. One of the things that I've always done is I've required the maintenance director to report to the center when the fire alarm goes off for no obvious reason, mainly because they're very sensitive systems and they don't go off for just no reason. And our maintenance director for that day saved the day in many ways, because I mentioned we were on the night shift and we only had 14 staff members there. This is the group that we spend the least amount of time with in purpose of training for EPP. That's our reality. We just don't spend the time there that maybe we should have. So when the maintenance director arrived at that time, he was the most efficient, the most senior manager in the building at that time. And he is the one that started and directed that evacuation and emergency plan. Without him, I really don't know what we would have done. The other thing that we did that is, I think, critical, and it was maybe good luck or good planning. In May, we did a QIPRO project focused on patient contact information, because we realized that our face sheets maybe had some really inconsistent, bad information on them. So we went ahead and had a whole overhaul social work and nursing work together to make sure those face sheets were correct, with emails where we could, phone numbers, obviously, and addresses. And we then started as a requirement to print the face sheets once per week, admitting approximately 40-some patients a month and discharging nearly the same, that there could be some inconsistencies from one print to the other. But it became critical for transfer to the next facility, and it became critical for our communication plan. And I mentioned, yes.
How are you notified that this was going on at your facility?
Well, I think I have that coming up. The EPP plan was in place and reviewed, and we talked about the fact that we had not spent hours training for that, and it wasn't covered. Next. So Tracy just asked a good question. It was says, well, how did I know what was going on? I don't live around the corner, because the neighbors around the corner said they felt the explosion. I don't live around the corner. So I live actually 45 minutes away. It was the longest 45-minute drive I've ever had. Well, I started getting calls at 4 o'clock in the morning, and I didn't answer the call because I didn't hear it. The maintenance director called me 7 times, and 7 times I didn't answer the phone. The 8th time I saw the phone and I called him. And this was really important, because empowering your staff to call anybody they can call when they can't find you probably saved a lot of lives and saved the building structure as well. The phone list needs to make sure that the phone list includes those persons above yourself or in addition to yourself. If it's a smaller organization and there's other people that are in your organization that wouldn't necessarily be in the communications tree, you might want them. We made sure that everybody was on that list. So when my maintenance director and the director of nursing could not find me, they called my boss. They called anybody they could find to get to that building, because somebody needed to start working with people. So by the time I got there, there was already a very beginning part of the evacuation in process in terms of discussion. We hadn't made an exact decision, but we were moving people away from that affected area. Good luck. Unfortunately, the blast happened when residents were in their room and in their beds. So it did minimize a good amount of their anxiety. They weren't as worried as they might have been seeing us rushing up and down the hallways if they had been in dining rooms or if they had been at the nurse's desk watching what was doing. And I've already mentioned about the lowest level of staffing. We were not understaffed that night, but on night shift, we simply don't have the same number of folks. It's only 14 nursing personnel in that building that night and no one else. And the only other person that came to the scene when that alarm went off was our director of maintenance. Next. This is the inside of the building. You can see on the right-hand side is the kitchen area. The left-hand side was some clinical space. The whole building just sort of imploded on itself. Next. The administrator and we served as incident command inside the building. And despite my wanting to put a vest on everybody, I only got mine on, but it was a good thing I had it. And I recommend that everybody get a vest and just hang it on the back of your door, because it did serve as a reminder to everybody inside the building who was in charge from the facility side. Incident command is clearly designated by EMS outside as well as inside. And when EMS needed assistance and the fire department needed assistance, I often heard that lady over there. So it helped everybody, I think, to know that I was the one that had the alarm, the incident vest on. I'd like to tell you that I got the vest on the director of nursing, but she threw it on the ground because she said we don't have time for that vest. I said, I know, but that's what we're supposed to do. One of the other important things that we did, and I've trained the staff to do, is we will always follow the lead of EMS and search and rescue. They are the experts in that field. We are the expert in our patients and our care, but we are not professionally trained in fire and EMS. And this allows them to help us more. Having somebody running around telling everybody else in fire and rescue what we're going to do isn't going to be helpful. And the staff were very aware that once those professionals enter the building, they are in charge. They did declare the scene a potential for mass casualty, which enabled us to have an enormous amount of resources from the Washington metropolitan area. There were vehicles I didn't even know were attached to emergency management there. It was the police were there to secure anybody from coming in that shouldn't be in that area. So they are the ones that can really access. So teaching your staff to listen to them, follow their directions, and you as leaders not challenge what needs to happen, like I am with the office chair going down the hallway. We don't evacuate with office chairs. Well, yes, we do now. So I just have to listen. Together, incident command. Yes, Tracy?
Good, you caught that cue. I put that in my notes for the next session. That's going to be my cue.
Sure.
There are a few questions in here that maybe while we're on this slide, we could answer if you don't mind.
No, we could take a little answer break.
Okay, so the question was, do you have maintenance on staff 24/7 at the facility?
No, I wish I did. I only have an on-call. I have 2 full-time maintenance personnel for that building. It's a newer building built in '96. And it's been well maintained. He was there still with us for 15 years. But I have always had the requirement as the administrator that the maintenance director will report to the building when the alarm sounds for unknown reason, not an obvious patient pulled or staff born to popcorn again. They don't know because those buildings are so sensitive. But no, I'm not fortunate to have 24-hour maintenance.
Okay, and another question was, do you have an emergency team? Like, do you have an emergency preparedness team?
Well, in theory, all of the department managers are the emergency team, but no, I wouldn't say I've designated specific people to be in an emergency team. I guess we just managed it. At that point, it was an all hands on deck. But prior to that, we had, of course, the director of nursing, maintenance, myself, social work, director of sales and marketing. And that was about the core of an emergency team. And then depending on that, we would add in.
Okay, and another question we got was, and maybe, this is just the alarm company that you have. Does that alarm company have a mechanism that then notifies your maintenance director that this alarm is going off?
Yes, we have both. We have a separate dialer that goes from the building to the alarm monitoring company. And you can set up, at least the different companies that I've worked over the years, that alarm company, monitoring company, you can advise them who you want to have called. Of course, the facility also calls 911 and the facility also uses its own communication tree. But when I go to a building, I meet with the alarm company, the monitoring company specifically, and ask that my name be added. And I also add the director of maintenance.
Very good, thank you. I think now you can continue with your regularly scheduled program.
Okay, I don't know if it's that exciting, but it's top bill. But so we were talking about the evacuation. So one of the things that in our emergency preparedness plans, there's 2 things. We're supposed to have a memo of understanding regarding transportation, how we're going to get people to the evacuated site, and then we're supposed to have an evacuated site. Genesis Healthcare has some buildings close by, but not really. And that some of these plans we inherit, when we show up to a building, oh, we set up the local church 20 years ago. Okay, well, that's good. We'll go on to the next part of the plan. So, our plan wasn't very different. We called the ambulance company that morning at 5 a.m. I called the owner and I said, looks like we've got a problem. How many ambulances can you send? He said, I only own 4. Well, I had to move 111 patients. So with emergency management, we decided we were going to evacuate the whole building because we had no utilities at all, no water, no air conditioning, nothing. And the temperature is rising and there's no way we could stay there. There was no smoke in the building because there was no big fire, but we couldn't stay there. So when we met with EMS, we talked about where do we go and why do we go there? And they are incredible folks, but they don't know our business. Next. You know the needs of your patients. You know what resources you need to take care of them. You know everything about what you're going to need to achieve a positive outcome. Some of the emergency management folks on the call will know that there's also a huge risk of injury, etc. once you get to the evacuation site, because you are now out of your element and you're going to try to provide care. Now, mind you, I had been working with Incident Command inside the building, and I was relying on Sean, was his name, very helpful. I was not willing to make a move until Sean helped me to make that move. Imagine how scared I was as we were evacuating when he said to me, by the way, when you get to the evacuation site, you and I are done. I said, what do you mean you and I are done? He goes, emergency management takes over. My job is to make sure you're safe, you're out of here, you're in a next safe place. So one of the things I do strongly recommend, even though we don't have a lot of time, is to at least introduce yourself to the emergency management agency. So you at least know their name, they know your name, and maybe grab their phone number and put it in your phone. Hopefully you never have to meet them again. Same with the fire department. And I'll be honest, I didn't have a chance to do any of that. So if I do this again, at least I'm going to show up and I'm going to ask. You have to remember our infection control protocols in the middle of all this insanity. We were lucky. That's where the luck came in. 3 days before the blast, we cleared our last COVID patient for the moment. So we were not having any active COVID symptoms in the building, but we had to consider that where we went. One of the things that we needed to talk about is communication. So how did everybody in the community know? How did our patients know? How did our staff know that this was an emergency? Well, a lot of us have spent a lot of time over the past 3 years having to make mass communications to families via text or via email. Some companies have retained other companies to do this. And it is was a significant lifesaver. So if you remember, we had that QIIO project back in May where we updated and ensured contact information for families was very accurate. When the blast happened, as you saw at the beginning, it was on the news. So everybody who had a family member at Larkin Chase, you can imagine, was super scared and very, very nervous about what was going on. We did send out a mass text and a mass email very shortly after the blast to advise them that we were there and what we were doing and the potential for evacuation. The same information went out to the staff and called for them to come to the building. So we did have extra staff after that mass communication went out.
Now, Stacy, how did that mass communication mechanism happen with your building?
Okay.
Was that you guys on scene, or was that someone else that you had designated outside of the event area that made sure that those notifications went out?
Actually, I did not have internet capability to send that out. So I had to call somebody else to do that for me. So we were lucky in that somebody else had that access. We use a company called Regroup. They're great. And I do know that there's a lot of other really great companies out there that provide the same service. But think about if I had to call 111 families and say, oh, I'm sorry, the building's blown up and your mother's now at the senior center. We didn't have the manpower to get people out safely, never mind start making phone calls. But we did have that ability. And I strongly recommend that if you have that ability, that you have somebody that's not going to be involved in the evacuation or the management of the evacuation site able to send a brief message out. And it is literally was like a 4-sentence a text message or email that went to 109 people. We only had 2 patients who families, excuse me, that don't use email or text. And most everybody knows who those 2 are. Next, please. This is the hallway that goes out to the back of the building. On the right is the laundry and on the left is the kitchen. If you look on the right-hand side there, you'll see that's the back part. Well, you can't really see what it is, but I can tell you it's the kitchen. So to say that, you know, we were very fortunate, we really were. Next. So we talked about that evacuation site and the potential to go to the local church or the local elementary school. We were supposed to go to an elementary school that was available now as offices for the county. It wasn't a current occupied school. The county had built a new school. So this was county space. So that made good sense. So the fire department decided when we were going to evacuate that we were all going to go to the elementary school. So if you've been to an elementary school from the 60s, there's a lot of brick classrooms. They're very small. The bathrooms, they did have adult-sized toilets in them, but there's not a lot of space for movement in those bathrooms. They have stalls. And we need a lot of stuff, and we don't have personnel to assign to all these little classrooms. Well, again, you all are the experts on your patients. You know what they need. So to evacuate for any length of time, I needed to bring the medication carts. I didn't have time to pull meds. We just pulled the whole carts. All the carts went out the door, and the fire department was super helpful in their transportation vehicles, their big buses and other vehicles I didn't even know they had, loaded up medication carts and oxygen, incontinence products, blankets, pillows, Food, the fire department and emergency management did supply cots because I don't really have a cot. Here's another good luck. Our kitchen did not have any space to store the emergency food. So thank goodness it was not stored in the kitchen. So that is a lesson, maybe, that if you have the ability, take a look. When you're going to rotate your emergency stock, move it to a different closet. We needed a building that had the ability to do a little bit of cooking because we had to serve 2 of our emergency food items, or meals rather, at the evacuation site. So the kitchen had to bring, utensils, paper, all that stuff that's in that closet that half the time we don't even have a key to, right? So I would say you need to find your key and you need to make sure it's not in the kitchen area. And I think if we had gone to where the fire department wanted us to go, we would have been farther away. One of the things we learned was we needed to go back into the building, into the safer parts, of course, and get things. Like we had to get some things out of the medical records. We had to get, certain things we didn't know we would need.
We have one question, Stacy,
Yes.
about when working with the first responders and their approach to the patients. Is there some way that you can quickly brief the responders that are on scene about maybe a particular patient's condition that might be made worse or may escalate a certain type of behavior just because of the nature of this traumatic event? While not consulting a barrier to the experts doing their job most efficiently, in other words, not getting in their way, which I think is very diplomatically worded. So they don't know your patient population, and they don't know the type of conditions that your residents have.
No.
So were there any issues in communicating with the first responders at the time about, so-and-so is, maybe going to react like this, or was it more of a scoop and run type situation?
I would say in certain parts of the building, it had to be a scoop and run because they were in areas where the roof was structurally compromised. In general, I observed the staff were side by side with those emergency management folks when they were taking patients out of beds. Telling and explaining to patients that we had to leave. And I could hear patients saying, I don't want to leave. This is no reason for me to leave. Or no, don't touch me. Because, they didn't understand some strange big man in a big suit and, it's almost like a spacesuit, I would imagine it 4 a.m. So we were fortunate in that we did not have a secure dementia unit. I have been in buildings with secure dementia unit, and that would have been a major concern for me to have met with incident command to talk about how we're going to do that, because those residents are at risk for wandering, etc. In the video clip, you saw patients lined up in the hallway. They were lined up next to the exit, ready to be moved out at any minute. So we sort of stayed with the residents on that side and assured them that, yes, it was scary, and yes, it was an emergency. And the emergency management staff and fire department worked with the limited staff that was there to go in and out. And I did hear staff explaining to certain people, oh, she's a bariatric patient, we're going to have to, do this and that. We're going to have to move her in the bed. She can't be moved. She has a recent, hip replacement. We can't scoop her up in an office chair. So we did have that good communication, but I would not say it was formal. Next, please. Here's the kitchen. So every time I see this slide, I'm humbled by the fact that had it been for 1 more hour, this kitchen would have been fully staffed getting ready for breakfast. So that leads me to sort of an sort of things that we usually talk about. And that is that you have to know who's on your time clock. You must insist that every person who's in your building be on the time clock. And in the kitchen, for those administrators on the call, you have that one cook who comes in early. She doesn't even go on the clock because she doesn't want to be in trouble, but she wants to make something special. She wants to make the cake just right. She wants to do this just right. We can't have that because I wouldn't have known. In the public reporting, you'll notice that if you go in and search and look around, there's plenty of video to watch. The fire department speaks to the person that was rescued out of the bathroom. Well, I said, I was told that everybody was out of the building. Who got rescued from the bathroom? Well, there was one person who was in the building off the clock and was not supposed to be, sleeping in an office because of transportation, and didn't want to say anything to anybody. But of course we would have made arrangements for him to have a different shift, a different schedule, whatever, but I didn't know. So I think if you can meet with your staff and say, please, if you're going to be here, be on the clock. Not only is it a law, it's the best thing for us to do in the event of a problem. Next. Okay, so at the evacuation site, I learned from emergency management, you do not let the family members into the evacuation site. You establish a reunification area, which is not the same. So we were in a grocery store parking lot doing reunification, where I went to reassure families that I was there, had a relationship with my family, so they were okay with that. Some I didn't know because they didn't come, but they did that day. And then I had other people in the evacuation site, such as the medical director was there at that point, all of our medical providers, nurse practitioner was there. It was the day for the psychologist to come, thank goodness. So we directed her to go to the evacuation site. Another thing that we have to remember is HIPAA. Family members are scared. I get it. I was a little scared myself, and they want information, but not everybody's designated to receive that information. So the last thing we want to do is to add to our bucket of problems by disclosing information to people who aren't supposed to have it and then causing another drama. And I can't say this enough, because I'm not a professionally trained anything. I'm just an administrator. And I have that professional training, but that's all. So me making statements about what happened in that building would have been very wrong, because I would have said, oh, well, the fire department said it was a gas leak and it looked like a gas explosion to me. And guess what? No, it was not. You can say the wrong thing and create more problems until you have very good, accurate information. It is okay to say, we do not know. I'm focused on making sure these 111 patients are safe and sound as fast as possible. And sometimes the people we work with don't understand that. They want an answer. I still have families calling me saying, Stacy, when is that building opening up? Because the building is still closed. Well, why is it still closed? That's ridiculous. You mean you can't find people to build a building back? Well, we can, but you have to do a thorough investigation. Next. So I don't know about you, but the only time I've ever seen orange X's on a building, or the emergency management folks on the call know that little X where you put the time in and your initials, is like from Hurricane Katrina or some evacuation. But this is what the inside of my building looks like now. It's covered in evacuation marks, as it should be, and it was correct. But that never ceases to bring this reality back to the fact that, you know, this was a big deal for us. Next. So what do we do now? Well, the building is still closed, and transfer trauma is a huge, real reality for me. I have patients, staff, and families who regularly exhibit signs of transfer trauma. I'll get a call from another Genesis administrator who says, you know, that nurse you sent over here, I thought you said she was really good and she was a big team player. I said, she is. She's the best nurse I have. And they said, well, you won't believe this. She's calling out. She's arguing with the director of nursing. She has a problem with this. She has a problem with that. And I couldn't believe it. But I step back now, and I think she might have an issue with the transfer trauma. None of us got to say goodbye. We were ripped out of Larkin Chase at 4 o'clock in the morning. Patients, families, they bond together with roommates. I'm going to bring cookies for your mom tomorrow. It's her birthday. My mom, we're going to have cake. The staff, we didn't get to say goodbye. Patients that eat lunch together, they didn't get to say goodbye. I'm an administrator for 35 years. When I first started, everybody ate in the dining room. Everybody was alert and oriented. We had a few patients that made their own beds. We don't have patients like that anymore, but they do connect with one another on a level that maybe we don't even understand. But we had no opportunity to say goodbye, no opportunity to have closure. So when I reopen this building, I have got to spend some significant time figuring out with them, how are we going to address this issue of trauma? The fact that our building blew up, the fact that we didn't get hurt, that's our blessing. But it's really huge. And I think that's going to be my hugest challenge to overcome.
Do you have any plans or any ideas about how you might memorialize or commemorate this event to help your staff to see, yes, that happened to us, but we've moved on and we're not going to forget about it. It's
I do
public.
have a silly idea, but I have to steal it from the Ronald Reagan Library in California. If anybody's ever been there, it's a pretty spectacular place, but they have a piece of the Berlin Wall there. And it's very moving. It's just a piece. And everybody goes up to it and sees it. And there's all this graffiti on the wall. And it's a real symbol to what he did to remove the wall in Berlin. So I'm going to try as best I can. We have the doors, the exterior doors from the back blew off several hundred yards away from the building, and they're very mangled and ugly, but they're a symbol of what happened, really. So we're going to safely somehow figure out how to put that maybe in our courtyard where we can sign it or see it or whatever, and know that as ugly as that door is and what happened there, we can start over. We can do something new. And I think a physical symbol of rebirth in that area and regeneration will be huge. We do not know what's caused the explosion. I want to know that more than anything in the world right now. The delay in reopening the building was not released to us until December of 2022, because I kid you not, everybody who ever touched the building has to be included in the investigation. So I jokingly tell people that if you delivered a newspaper, you're part of the investigation and you have a lawyer to help you. So because it's a huge claim, and it's a lot of money, of course, and a lot of finger pointing, and none of which has anything to do with me. I'm all about, opening the building back up, but all those parties have to be treated respectfully and legally. And that takes a long time. I was very impressed with the folks that do forensic investigations who have PhDs on PhDs, and who knows anything about fluid dynamics. Well, there are real people in this world who know a lot of that kind of stuff. And they take every little bolt, every little wire, every little screw to figure out what happened. So I'm hopeful in the next several months we'll know. The building is still closed, and that's hard on all of us. We all want to go back to Larkin Chase and be our family, but we're never going to be the same. People have moved on. Some of our patients have passed away. So we have a lot of work to do besides the obvious hammering and nailing. There's the supply chain issue to deal with. At all the back of the building, nurse call, fire alarm, kitchen, laundry, phones, internet, cable, has to be redone. So I feel like there's a lot to be done, but I do want to, before I close, really is to just say that, the collaboration between EMS and emergency planning and 911 and any kind of description you want to have, that relationship must happen. And we must, in the buildings, at least call and introduce ourselves. We don't have time to make the manual perfect anymore. We don't have any more time to do anything else in the centers. So take what you're already doing and make it a little stronger so that you can have more of an all hazards plan and rely on the expertise and professional training of the people in your community. That might have been my good luck. Next. Tracy, do you have any questions in the chat, or how do you go forward with this part?
So Mary Ellen, our chat monitor, has been monitoring questions, and we have addressed some things, but Mary Ellen, you want to unmute yourself and maybe direct some questions Stacy's way?
Sure can. Some of the questions, Tracy, you answered. Can you hear me okay?
Yes.
Okay, so a couple, I'll try and condense a few that were similar. One question, did you have patients on ventilators? If yes, how did you manage evacuating those patients? And in the same realm, what was the greatest barrier to evacuation process in terms of bedbound, oxygen, or other equipment?
We did not care for patients with ventilators. So that might have been another good luck that I had. So I didn't have to worry about that part. We do have dependent oxygen patients. And that's where the oxygen came in. We had to make sure that we had to get our little E-tanks back out, line everybody up. I think the biggest barrier to the evacuation was the physical conditions. It was dark. we couldn't see each other. We were, I honestly think that EMS in the building was as concerned about what was the next step, because we didn't know structurally what was going on in the back of the building. So we had to pull everybody to the front of the building, and then we had to move so fast. You don't evacuate 111 patients in 4 hours, start sitting around talking about it, and let's have a meeting. And we had to shove people outside quickly. So there was a lot of supervision and making sure we knew exactly where patients were and exactly who was with them, so we didn't have another injury or an additional, or any kind of injury rather, from that. So that was a barrier, I think, that my friend Sean from 911 and I identified early on, was we have to move very fast, and nobody's moving. So the barrier is, how do we get people to move fast in this area where we're not the professionals? We don't move fast in long-term care. We don't do that.
Great. Another question, did your emergency preparedness plan include provisions for an off-site command center in the event that your on-site incident command center was compromised? If so, was it opened or not feasible?
We did not have that center-based off-site incident command. Our plan only had incident command in the building. I did introduce myself to the off-site incident command for the 911 service. So I don't know, it was such a unique situation due to manpower, if I would have had the time to set up a second one for the center-based staff.
And another question that just came in, how is your relationship with local hospitals? I have assisted with several nursing home evacuations and found the hospitals to be able to take the critical patients quickly.
Correct. It's okay. It's not great. I'd like to say that it was just perfect, but with COVID, we haven't spent a lot of time building those hospital relationships. We did have 3 patients that I think had anxiety related, that we made the decision to go directly to the emergency department, and they stayed there and then came to the senior center just to have them evaluated. But we do take some more critically complex patients. It's not necessarily a lighter care building, I would say. We do everything but the ventilator, I think.
And that's it for questions in the chat box at this point, Stacy. Thank you.
Okay, thank you.
Okay, so let's go to the next slide. So if you wake up in the middle of the night with a burning question that you didn't think of, or you asked one and we missed it, here is Stacy's email, and Mary Ellen is going to put that in the chat for us. And my email will also be included, and we'll get you connected to Stacy as best as we can. And for those of you who are now going to go back and look at your emergency preparedness plan, perhaps through a little more realistic lens, please don't hesitate to contact us for help with that, or go to my favorite resource, which is the ASPR Tracy website, and look at their emergency preparedness materials. And Mary Ellen is also going to put that chat in that link in our chat box. And we're going to go on to the next slide. We of course want to thank you so very, very much for joining us today for this presentation, and we want to thank Stacy for taking the time over several meetings to work with us and get this PowerPoint put together and really get her message across. We do really appreciate, Stacy, your time, and I have screenshot a couple of the kudos you have gotten in the chat, so I'm going to send those to you after. Our next session, because this is just the first of a 4-part series, is going to talk about a hospital response in Thomasville, Georgia during Hurricane Michael. And you can see that there's the picture of Hurricane Michael, and that it is on the Gulf side of Georgia, where they're not usually approaching from that side. They're usually coming from the other side, so it was a little different. And in this particular story, the patients were sheltered in place, and the facility, it did in fact take in extra patients. So the name of that presentation is You Don't Know What You Don't Know, and you'll find out why. See, there's your carrot. Come to the presentation and find out why that's the title. You can register for that by using the QR code on the screen, or Mary Ellen is going to share the registration link. It is also on the flyer that was sent out, and we'll send that out again next week, just to make sure that we keep nagging you guys to join us. And next slide. This QR code is going to give you the link to an evaluation via SurveyMonkey. And once you have completed that evaluation, you will get a certificate of attendance. I know everyone always asks about CEUs. That is a slightly more complex process, but we will try and get our heads, procedures wrapped around that for the upcoming presentations. And then next slide. We, as a planning team, have really put some thought to this, and we have already received reach outs for people who are requesting the recording of this specific session, and I imagine it'll happen with the others, so that they can use it as a training in their facility. So one of the things we're talking about is extending this series so that we do this monthly. And then these real world events, which, let's face it, anyone can come up with a scenario, but none of it's going to be the real world event. And then you guys can use these recordings as tabletop exercises or training tools within your facilities with your staff. I'm looking through my notes to make sure that I hit everything, and it looks like I did. And we are at 12:57. So with that, stay tuned on the coming attractions.